So I'm very happy that we have come up with this program, which is basically empowering general ophthalmologists for COVID compliance. This topic was actually given by Dr. Ajay, and I'm thankful for that. And basically, we are going to share this program as a training program for general ophthalmologists, by which we will be deciding how to train them so that they can actually identify and do uh, the referral basically for ophthalmology for diabetic retinopathy. So that's why I have used the word human in allowed to AI. Dr. Ajay Kudani is a professor, director of Mumbai Retina Center. He is our senior panelist today. He will be talking about when to indulge and how much. He has 60 publications and more than 200 presentations. Very active VR surgeon for a couple of decades. Dr. Mohit is a consultant of Agency Hospital Limited. He has been involved in active retina treatment for a decade. Many publications and presentations to his credit, and he has gifted a logo to this program. So that's the beauty. Somebody has given something to this program, and it's a composite effort. Dr. Manish is an active VR surgeon here in Kanpur who believes in taking anything and everything in retina, and he has been involved now for almost a decade and more. Dr. Abhishek Dikshit did, after doing his VR fellowship from CHATURVEDI, has practiced as a consultant in Sitapurai Hospital. Is currently practicing in Varanasi and has a career of active VR surgery for more than a decade. And Dr. Abhijat is a young budding ophthalmologist who is a senior residency at Subharti Hospital, has two international presentations, one Best Paper Award, and is having experience of being panel for two ICF, AIOC. This program has been mastered and patronized by Dr. Lalit Verma, who needs actually no introduction. He's in AI, our president of AIOC. So that is the panel with which we are entering into our second consecutive session of VR for general ophthalmologists, which is a human analog. So a brief introduction about how artificial intelligence works. Artificial intelligence is basically, this was first told by Dr. Haldipurkar, that basically a computer is recognizing a picture, it is dividing those pictures into mathematical breakups, and then it goes through certain filters, and those mathematical filters, they get converted into a picture. So that's how a computer is recognizing a picture into a picture. These are certain filters which are used when a computer is deciphering this photograph into a plot. So there are certain filters by which AI is working. Now, this is a OMR sheet we all have seen during our PG examination, and it works on the basis of that picture recognition. If we want to give some more color to this picture, we will add fingerprints and we'll add some other features so that this becomes more meaningful. Another example of picture recognition is, say, this computer with AI can recognize this as a dog, as a normal retina, or a diseased retina. As of now, AI in diabetic retinopathy remains a screening tool, and purpose is to identify treatable diabetic retinopathy patients. Now, this was in April 2018. FDA approved this machine, which is basically a software, IDXDR software, which comes on a Topcon computer camera. And what it does, it just deciphers between more than mild diabetic retinopathy and less than mild diabetic retinopathy. It compares a picture of ETDRS chart, which is a level 35 chart, and on the basis of that, it decides whether to refer a patient or to keep it under observation. If it is to keep it under observation, then it will be telling the patient to come after 12 months. It has a sensitivity and a specificity of 90%. Now, on a similar basis, we have introduced the concept of human analog. So our aim should be simplified. Our criteria, identification criteria should be simple. The tools with which we will be handling should be easy to handle. Our target should be simple and achievable. And that's how we do a predictable outcome. So basically, this as computer is doing to the program of diabetic screening, we can develop a human analog. So we did our first program. This AI was introduced into diabetic retinopathy in 2018. We did in summers of 2018 this program of CME with difference. Dr. Avijat will be telling more about it. The thing is, when we teach our students, we teach so many things, so many classifications, so many features that it becomes very confusing. But when we give to the computer, we give it in a very simplified form. So the thing is, if we can simplify, so diabetic retinopathy classification is getting simplified, and if we can give that simplified information to ophthalmologists, they will be in a very nice position to understand the disease and identify and treat. So this is a population survey data which shows that this is your population, this is your prevalence of 20% with 8.7% diabetes and 24% on an average progressing to diabetic retinopathy. So this is our burden of diabetics and retinopathy patients. This is the burden of proliferative PDR cases. And if we think our AIOS members to be 22,000, the PDR load per member is actually not much. So a burden is manageable, and if each ophthalmologist get the capacity of identifying treatable diabetic retinopathy, the job becomes very simple. We presented the similar thing in our other conferences at Uttarakhand. Luckily, when I was working on my project, I came out with this document, which is a WHO guideline, screening guideline of 2020 based on European studies. And what they are doing, you see, they are doing exactly the same what we have been doing. They have identified these 5 photographs for identification, and for macular edema, either there is no macular edema or macular edema not involving the center or macular edema involving the center. So what they have done is they have simplified the criteria, which are very similar to the criteria which we have used. So they have developed a referral threshold based on whether patient needs reference or not. So if it is screen positive, we will refer. If it is screen negative, we'll keep it under surveillance. Earlier, the review was the patient should come after 1 year. Now they have relaxed it to 2 years. And what they are doing, who can do? Doctors, family doctors, optometrists, ophthalmologists, endocrinologists. So they are actually talking on the similar terms as we are talking, and that is the relevance of our program. And what has it yielded? Their visual loss, the burden because of visual loss in 2 studies have gone down over a period of decade by using this model. So that is the use in our perspective. So ladies and gentlemen, that is the thing which we have introduced. We are working on it for 2018, and I'm really thankful to AIOS and our Chairman Scientific Committee, Dr. Partha Biswas, for allowing us to share this program, and I think it will be useful. So we will be talking, that was the concept introduction. Dr. Avijat will be talking about previous experience. Then we will have takeaways on clinical thing by Dr. Mohit and by Dr. Manish, and investigating by Dr. Mohit. And then there will be a very nice talk by Dr. Ajay Dudani on takeaways on diabetic retinopathy, how much to indulge and when. And then Dr. Abhishek will be talking about surgical indications from the point of view of diabetic general ophthalmology. So that's it. I think I'm in time and I invite Dr. Abhijat Chaturvedi to come forward and make his presentation of our previous experiences with these. Thank you very much.